their social habits, caffeine, alcohol, smoking, and other unusual drugs. If there is a history of ischemic heart disease, heart failure, or mitral valve prolapse, it again carries a bit more relevance because these may not be simple ectopics, they can progress into sinister arrhythmias. And a family history of sudden death is always more important when patients are presenting to you with these symptoms. So what are the kind of investigation one does? Well, start off with a simple 12-lead ECG. If you're lucky, you'll pick it up, and if you see what it is and there's nothing to be unduly worried about, you could go on to reassure your patient. Ruling out structural heart disease is certainly important. It is useful to quantify the amount of ventricular ectopics by doing a 24-hour Holter. A 24-hour Holter, if it shows less than 10% and the patient is fairly asymptomatic, can be controlled with medications. If the burden of ventricular ectopics is more than 10%, you should be aggressive in trying to bring down the percentage of ectopics. And if it doesn't settle down, these are the patients who should be referred to electrophysiologists for EP studies. A TMT certainly helps in both in prognosticating whether the ventricular ectopics are related to exercise or improved with exercise or brought on with exercise. So these are the kind of things one needs to look at. And again, whether it's unifocal or multifocal, I think that depends mainly upon what the LV function is. So let's have a look at what you're going to do with this, and I think this is probably the most important slide of the talk. Your management plan is based upon whether there is structural heart disease, what is the frequency, whether there is any ventricular tachycardias as well, in addition to just ectopics, and how frequent the symptoms are. If you had a patient who had a structurally normal heart, the ventricular ectopics settle down with exercise and they were infrequent, all they need is reassurance and nothing more than that. If they had frequent symptoms and no structural heart disease, then beta blockers can be used. I generally use a cardioselective beta blocker such as bisoprolol, which is a once daily dose, got a good effect, doesn't have any other issues to think about. If patients had no structural heart disease, had quite frequent ventricular ectopics or non-sustained VT with symptoms, you could add on ablation, particularly if the burden is quite high. When there is structural heart disease, continue the beta blockers, but do take a view about assessing their risk for sudden cardiac death, and these may be candidates for implantable loop recorders or even ablation. I am not an ablator, so I wouldn't be speaking much about ablations, but there are enough renowned gentlemen in the audience who can speak about that. But when there is LV dysfunction, there's ventricular ectopics, non-sustained VT, and frequent symptoms, these are patients who should be considered quite closely for primary prevention. Most likely with drugs, you may need to supplement it with an implantable defibrillator. So ladies and gentlemen, in conclusion, majority of the patients that you and I see with ventricular ectopics are asymptomatic, and most of them have got benign features. It is worthwhile looking at the morphology, the frequency, and the complexity of the ectopics before you plan anything different. Rule out structural heart disease, which certainly would make a huge difference as to how you manage them. Be cautious about using anything more than beta blockers, because the other drugs have been shown to be proarrhythmic and should be used with caution. Catheter ablation certainly for right ventricular outflow tract tachycardias, ectopics, left ventricular outflow tract ectopics, or sinus of Valsalva ectopics is quite effective and can be curative. If not curative, can certainly reduce the burden of ectopics. And in specific subtypes, particularly those with an ischemic history or heart failure, one should be considering primary prevention therapy with implantable defibrillators. Thank you very much for your attention.
I congratulate Dr. Rajpal Singh for lucid presentations. I have a question for you. If somebody is a there is no structural heart disease and no symptoms, but they have got a complex means multiple ectopics, multifocal, or they get frequent ectopics, sometimes maybe non-sustained VT also, maybe around a couplet or triplets, and if they come for a routine checkup, so what is your approach? Do you no, because sometimes what happens is we get a reference from the other departments, as in cardiology. So with a long strip, there are out of 20 beats, maybe around 10 beats are ectopics. They are multifocal. What to do in these conditions? Because for this is for the general public, especially the physicians in the outside, when they practice, they get in preoperative ECGs. With these conditions, echo is normal, no cardiac histories.
Well, if the echo is normal, one needs to look at this echo quite closely, particularly if there is polymorphic or multifocal ventricular ectopics and non-sustained VTs. Make sure that we are not missing out any data to suggest right ventricular dysplasia. Yeah. If I would do a 24-hour Holter, if the frequency of ectopics is quite high, even in the absence of symptoms, I think prophylactic use of beta blockers should be entirely appropriate.
Now, as of now, today, I think when we talk about structurally normal heart, we should probably consider, if there are multifocal ectopics, we should consider a cardiac MRI. Because unless we do a cardiac MRI, we cannot rule out a structurally normal heart, and the cardiac MRI should be done by somebody who knows how to read a cardiac MRI. Yeah. And it should be done by somebody who knows how to do a cardiac MRI, because it's a gated cardiac MRI done. And many a times, we have found that these patients either have a cardiac sarcoid, which can be easily missed. We have a large series of patients. The second is the arrhythmogenic RV dysplasia, because echo is extremely insensitive in these two situations.
At times we get multiple ectopics with the bradycardia, low heart rate. That time, how to do beta blockers can be given with all?
Well, the beta blockers have to, you see, what you're getting is ectopics. As a result of ectopics, your own intrinsic beats are delayed. So I think if you suppress the ventricular ectopics, your intrinsic beat should be better. So I would have no hesitation if the patient is symptomatic to use, start off with the low dose beta blockers if you're concerned.
Is there any cutoff heart rate for that? To stop beta blockers below certain heart rate?
I would go by symptoms rather than the rate itself.
Not this. Thank you.
I conclude the session. Thank you very much, Dr. Rajpal Singh.
Thanks for your time.
Thank you, sir. I now request Dr. H. Prabhakar to hand over a certificate of gratitude to Dr. Rajpal Singh. I now request Dr. Rajpal Singh to hand the certificates to the chairpersons.